We'll start in the next 2 minutes. A very good evening to one and all. Uh, Today, the topic for our meeting today is how and when to use new drugs in metastatic renal cell cancer. This is the agenda for the day. Today, we have two very well known speakers in the area of genitourinary malignancies. One is Dr. Amit Rauthan, who is a consultant medical oncologist at Manipal Hospital, and Dr. Sangeeta Goswami, who is working in MD Anderson Cancer Center. Initially, there will be two talks by our guest speakers, followed by a talk by Dr. Vishwanath and a panel discussion with our guest speakers by Dr. Linu Jacob. We thank Bristol Myers Squibb, Panacea Biotech, and Adlai Oncology for their educational grant for this meeting. Few housekeeping announcements. The internet connectivity, try and keep it good for seamless experience. By default, all the attendees will be in mute and listen only mode. Attendees can also choose to speak or ask questions by typing in the question answer section. This section is being recorded. To start up, we have Dr. Amit Rauthan, who is a senior consultant and director of medical oncology at Manipal Hospitals, Bangalore. He is a well-known medical oncologist, well-known all over the country, has authored multiple publications, and is a well-known speaker in various oncology platforms. Over to you, Dr. Amit Rauthan, for your talk.
Thank you, Dr. Santosh. Good evening, everyone. Thank you for the introduction, and I thank Dr. Vishwanath and both of you for giving me this opportunity for being here. If you will stop sharing, I'll share my slides.
Sure, sir.
So, right.
I'll just make you co-host just a second.
Right. Yeah, right. So you can see my slides, right?
Yes.
Right. So thank you, everyone. Thank you for your kind of giving me this opportunity of one of my favorite topics, and that is renal cell carcinoma. Renal cell RCC is a passion for us, and it is something that we've been kind of going with times, have been changing in learning how to manage it better. And it's been a learning curve. That's the best thing about RCCs, and we have seen how it has changed our patient's journey. So my topic would be talking on first-line therapy and how it's been changing. We've seen how we have moved from the cytokine era to the TKI era, and all of us have, or most of us have been trained in the TKI era, and we were all major proponents of using pazopanib and sunitinib as first-line therapy, and our major debates used to happen that should we go for pazopanib or should we go for sunitinib? And that's how we used to keep debating over our first-line therapies. But in the last 5 years, there's been a tremendous change after coming up immunotherapy. And the whole concept has changed, is moving towards immunotherapy in first-line setting. But we've known immunotherapy single agent has never done very well. And that's something that we're not very happy with as first-line setting, using immunotherapy as single agent, but immunotherapy combinations are the way we are leading the way forward. Now, there are two ways of combining immunotherapy. One could do the IO combination, the IO of Ipi-Nivo, or one could do the IO-TKI combination. And we have the 4 prominent trials of pembrolizumab, Nivo-Cabo, lenvatinib. This is probably what we'll run through quickly. So, starting off with the IO-IO combination, Nivo-Ipi came as an initial combination regime, and this was compared with sunitinib with the Checkmate 214 study. We've seen this study multiple over the last few years, looked at the data, and what we saw at the multiple analysis, we clearly saw that there was an improvement in the overall survival in the intermediate and high risk group, and that's the group in the middle. If you look at the intent to treat population on the left side, again, there's a significant improvement in the overall survival. But if you look at the favorable risk group, that's the one on the right, where we're not seeing the improvement in OS yet of Nivo-Ipi versus sunitinib. We're actually seeing sunitinib doing slightly better than the combination of Ipi-Nivo. Now, the way the regime developed, we started understanding better that maybe the favorable subgroups are not the groups where are so immunogenic and they are more VEGF dependent as of now. And that's why sunitinib possibly will be doing better. And the PFS curves with sunitinib was better than Ipi-Nivo. At least initially, we are seeing that separation is dramatic. What we are learning is slowly with time, we are seeing the flattening of the curve of the Nivo-Ipi, if you see on the right side curve. And that's what's the thought is that maybe with time, we'll start seeing a difference again, even in the favorable subgroup. But as of now, we know the intermediate and the high risk subgroup. Clearly, Ipi-Nivo is better than sunitinib. The PFS hazards were about 0.75, over hazards somewhere about 0.65. And even in the overall population, there is a benefit with time. So with this, the whole concept came that if our patients are metastatic, one could start with nivolumab, ipilimumab, if there is no contraindication to using immunotherapy as first-line setting. And one issue always talked about is when you use ipilimumab, will we get more toxicity? And that was always the worry. And in India, we've not had EP for a long time. EP just came in last year as an official usage, got approved by DCGI last year. And after that is where we have started using EP. Before that, we have had selected usage of EP in patients who could actually get the drug imported and use it. So again, our experience with Ipi-Nivo is limited in India, but what we have seen from the data, clearly Ipi-Nivo toxicity is the IRAs are there in the first 4 to 6 months, but after that, once the EP stops, the IRAs actually come down. And that's where this course over sunitinib toxicity goes on, and the TKI toxicity definitely goes on over a long term. In this study, we saw the quality of life. Clearly, Ipi-Nivo is better than sunitinib in terms of quality of life. So that's one way to go forward. One could use Ipi-Nivo as a first-line therapy, 4 doses of Ipi with Nivo, followed by stopping the Ipi and then just continuing the nivolumab. Now, simultaneously, after it was just the next year when the keynote data came out, the keynote 4 to 6 was looking at pembrolizumab, axitinib, comparing with sunitinib again. Now, in this study, again, we had seen the data. There was a benefit in progression survival, and there was also a clear benefit in overall survival. Now, in the right side, you can see the updated PFS curves, what we saw in this year's ASCO. And you saw sunitinib again, 11 months versus 15.7 months, clearly significant. But one thing that everyone's watching for is, will the curves of the combination of pembro-axi, will they flatten out or not? And even now, if you look at it slightly, you're seeing that the curves still continue to dip downwards. They're not yet flattening. And that's probably the one difference going to come out with Ipi-Nivo. That Ipi-Nivo curves you're seeing with time, after somewhere around 2 years, they started to flatten, and then they have remained flattened time of 4 years. And this is something that may be different. That's what the thought comes as. clearly you're seeing an improvement in the PFS, and there's a clear improvement in overall survival, hazards of 0.73. The significant factor is the overall response rate. It's 60% versus 39% with a 10% rate of complete remission. Now, again, that's not the only IO-TKI study. You have the Checkmate 9ER study, which was looking at combination of nivolumab, cabozantinib, and this was compared with sunitinib again. Again, if you look at the curves, very similar curves, as if at least when you look at the curves up front, they are very similar curves. You see the PFS improvement 8.3 months going to 17 months with a hazard of 0.5, and again a clear improvement overall survival, though the Nivo-Cabo has not reached it. And this is probably a less follow-up study. We still don't have a long-term follow-up of this study. But again, when you looked at subgroups, you clearly see the benefit in all the subgroups. Now, Nivo-Cabo is definitely better than sunitinib, be it favorable risk, intermediate risk, or poor risk. And also you're seeing benefit in all, even those high-risk patients you talk of bone metastasis. That's when you say they do poorly, but they're doing better with Nivo-Cabo versus liver met patients are doing better. This is another thing one could use as a combination. Sorry. Yes. Sorry, can you see the slides? Am I audible? Am I still there?
Yeah, Dr. Amit, you're still there, but you're breaking in between. Am I right,
Okay,
Dr. Sangeeta?
Switch off the video 1 minute.
Yeah.
Yeah, okay. So with the Checkmate 9ER data, we've seen Nivo-Cabo is again clearly better than sunitinib, all the subgroups, and it's approved again for first-line usage in all the subgroup patients. And this we've seen the clear data set which came in, and this is again looking at lenvatinib pembrolizumab in comparison to using sunitinib or in comparison to using lenvatinib everolimus as first-line therapy. So this trial was slightly different. If you look at the clear data, it was also using a third arm of lenvatinib everolimus as first-line therapy. The data of lenvatinib everolimus as second-line therapy has already come in. So this was moving it forward in the first-line setting. What we saw, a clear improvement in progression-free survival, 9.2 months with of 0.9. Now here, we are definitely seeing numerically at least the PFS is much higher and the hazards are much better than sunitinib. And even the lenvatinib everolimus in terms of PFS did better than sunitinib, though it's 14 months and the hazard was 0.65. And the overall survival, we have seen a difference between lenvatinib pembro versus sunitinib with a hazard of 0.66. The medians are not reached in both arms, again, because the follow-up is short. But we see lenvatinib everolimus is not better than sunitinib in terms of overall survival. But with this, we've seen lenvatinib pembrolizumab also get approved as first-line therapy. And this is a approved regimen for first-line setting in all subgroup of patients, favorable, intermediate, and high-risk IMDC. The response rates of lenvatinib pembrolizumab were significantly good. A high overall response rate of 71% with a complete response of 16%. And again, this is something about this regime which is CR rates. But of course, sometimes we need to follow it up long term, especially we need to follow up. So where do we stand? We have these 4 combinations. We have IO, and we have the 3 IO-TKI trial data. And you look at it, it's that there's clear benefit in in overall survival in all of these data sets. So what we have to do is learn how to use these regimes and which regimes to use in which settings. And this is something that we'll clearly learn better as we choose our patients better and follow up our patients in long-term use. Again, one could say numerically some IO-TKIs sound better than the other, but again, I don't think we can say that because we don't have long-term follow-up. It's clearly that all the IO-TKIs go better than the TKI alone. So how to choose first-line therapy? If you look at immuno with TKI combination, the pros of it is it's consistent benefit seen across all the IMDC subgroups. So especially when we talk of the favorable subgroups, again, we see this is doing better than the sunitinib. We've seen that the response rates are much higher. So patients who have a high tumor burden to start off with, an IO-TKI may be a better combination to start off with. And of course, there's manageable toxicity. So that's one thing good about the regime. There will be some TKI toxicity, and that could be a chronic toxicity. So that's one of the cons of the regime. But the other cons which still talked about is we don't have the long-term durability of response yet demonstrated. We've seen the 4-year data from the Pembro axitinib trial this year, and we still see there may be a little dip of the PFS curve happening. But again, the results have actually held on otherwise quite well in terms of overall survival. If you look at IO, the major prones, we know it is better in terms of overall survival and overall response rate when we compare with TKI monotherapy. The major advantage has been the durability of response and disease control. Those patients who respond, they get into a plateau, and those are patients who may actually not relapse for long term. And also it may be possible for this group of patients to stop therapy. So we may get some treatment-free interval, which may be possible. If you look at cons of IO, there is a toxicity of immunotherapy, Iuio combination when we use a CTLA-4 inhibitor. So that's something that may worry us. There is a lower response rate. So patients who have very high disease burden, we may be a little worried trying to use this. And what we are seeing in the favorable risk population, at least in short-term follow-ups, clearly it's not a very good regime. And it's not that we would offer it to all our favorable risk patients, but of course, long-term follow-up will tell us better. What I'd like to share is our experience. This is our center's paper. This ASCO, we had an abstract presented from our center of using combination IO-TKI as first-line setting. It's a real-world Indian experience. It is a single center retrospective study. We use first-line IO drugs. We use Nivo or Pembro as our therapies. Our TKIs were either axitinib or lenvatinib. We enrolled patients between Jan 2019 to Jan 2021. 22 patients were treated with IO-TKI combination. 12 of them received axitinib, 10 of them received lenvatinib. We had 13% patients who were in IMDC favorable risk, 59 in the intermediate, and 27 in the poor risk group. What we saw, we had 2 patients who got a complete response, that was about 9%. We had partial response in about 59% of patients, and progressive disease in 13% of patients. And overall response rate was about 68%, which is almost the same as what you're getting in most of these IO-TKI clinical trials. We did see grade 3 to 4 adverse events. 3 patients, one had colitis, one had pneumonitis, one had encephalitis, and all of these, the IO was discontinued. So this is something that we do see in practice. One needs to watch our patients very carefully because IRAEs can happen, and some of them can become even life-threatening. The TKI-related adverse events, 3 to 4, were seen in about 38% of patients, but these were managed easily by dose reductions, and most of these would be just dose managed. This is very early data set, very long, short follow-up, but we got a median PFS of about 22 months. Median OS, the OS at 1 year was 92%, medians have not been reached, but clearly we are getting almost the same results of an IO-TKI combination as what was seen in most of these IO-TKI trials. So we concluded that time with combination IO-TKI is a very effective first-line therapy in most of our patients. The efficacy we saw in all the IMDC subgroups. Combinations are well tolerated. The TKIs are managed by dose reductions. We still kind of think that at least with the lenvatinib, we are not happy with the starting dose of what IO-TKI is shown in the clear data, and we are doing it with lesser doses. Though the axitinib, we are clearly comfortable with using at full doses. And we believe IO combination should be preferred over first-line single TKIs, and that's something that we strongly believe in most of our patients, except that very slow growing favorable risk patients where we may want to avoid it for some patients. I would like to kind of end off showing why our fascination for immunotherapy is there and why it's going to remain in RCC. This is one of our patients, 60-year-old, who had presented in February 2020, cough and severe breathlessness. He had extensive lung metastasis in the CT, RCC, left lung with lung and bone metastasis, IMDC poor risk, clear cell. And this patient was so symptomatic that he was bedridden and he was on oxygen. And this was his scan of the lungs, if you see. These are clearly patients. I remember treating such patients even 10 years back. We used to try to treat them with TKI. We never got responses, either sunitinib or pazopanib, and all these patients used to just deteriorate and eventually die. Now, this was how he's presented to us, RCC with lung, extensive lung on oxygen. He was started on IO-TKI, and in just 2 months, in a month, he's clinically improved dramatically. The breathlessness went off, the oxygen went off, his lungs improved dramatically, he became completely mobile, and then he got back to almost normal and continued treatment. So this is the kind of response you can get with an IO-TKI. And this is something that I can clearly say I have not seen in the previous TKI era when we used to treat patients. Now, what we need to see is how long the IO-TKI response lasts, but that's something time answers. But this is the kind of response we got in this group, this patient. And lastly, this is my last patient I wanted to show. This is a female who came to us. This is a recent patient, not one of those included in our paper, which we saw. In March 2021, she had a right kidney RCC with lung metastasis and brain metastasis and presented with hemiplegia. She had clear left hemiplegia. Now, when we did her scan, you see that brain lesion. There was a big brain lesion causing edema, and there was midline shift. And we immediately got the neurosurgeon involved, and the neurosurgeon said, no, we have to operate her immediately. There's midline shift happening, she will deteriorate. The patient flatly refused. She said, no, I'm not going in for surgery. And she completely refused for surgery. So what happens is then we involve the radiation oncologist, tell them, can we give SRT to this lesion? What do you think? And can this patient improve? Now, the radiation oncologist says SRT can be done, but he says the edema may flare and there's already a midline shift. He says, I would not suggest it. She may actually deteriorate initially. So if you can operate, push her for surgery. Now, patient flatly refused for both, and we ended up giving IO-TKI. And this is what happened. In just 4 doses of IO-TKI, we repeated a PET scan, clear reduction in the lung mets, clear reduction in the RCC. But what was most significant is the dramatic improvement in the brain. The mass shrunk down, the edema shrunk down, the midline shift disappeared. And this is a patient who's not been radiated or has been operated. She's able to walk again, and she's now leading back to normal life. So this is the kind of responses you can get in the present immuno era. It could be IO-IO, it could be IO-TKI, but definitely this is changing how we are managing our first-line patients. So with this is the latest, actually this is not the latest guideline. Now the latest guidelines have further changed. So we see these changes in RCC in the last year. The Nccn guidelines have changed so many times. You keep shuffling the regimes and moving the older regimes keep moving to the right and then to the right, and they keep going out. We've seen first line in the favorable risk group. Pazopanib now has moved actually away from even the preferred regime. It is an IO-TKI as a preferred as a category 1 regime, but of course the other recommended regimes could be even these. In the poor risk intermediate, it could be an IO-TKI or it could be an IO-IO, and we will eventually have to choose our patients and then move forward. So thank you very much. Thank you very much for this opportunity.
Thank you, Dr. Amit Rauthan. It was a wonderful talk. In fact, your real-world experience was much more valuable than even the trial data. Moving on to the next talk, we have Dr. Sangeeta Goswami, who is a well-known expert in the field of genitourinary malignancy. Dr. Sangeeta Goswami is an assistant professor at the Department of Immunology and Department of Genitourinary Medical Oncology, Division of Cancer Medicine at University of Texas MD Anderson Cancer Center. Dr. Goswami obtained her medical degree from Guwahati Medical College in Assam and PhD in immunology from Baylor College of Medicine in Houston, Texas. She completed her internal medicine residency from University of Pittsburgh and medical oncology fellowship from MD Anderson Cancer Center. Dr. Goswami has published numerous original research articles and reviews in journals such as Nature Medicine, Nature Immunology, Science, and Science Translational Medicine. Her clinical focus is on treating patients with RCC and urothelial carcinoma. Her laboratory in the Department of Immunology focuses on understanding the cellular state and plasticity of tumor immune ecosystem and its role in determining response to immune checkpoint therapy. Thank you, Dr. Goswami, for joining us. Over to you for your talk.
Thank you, Santosh. Thank you for the kind introduction. And let me share my screen. I think I'm disabled to share. If you could.
Yeah, you can go ahead now.
Let me put it in a full screen mode. Okay. So good afternoon, good evening, everyone. It's morning for me here. It's a pleasure to be here today to discuss about the metastatic clear cell RCC treatment algorithm, second line and beyond. And our previous speaker gave an excellent talk discussing about the front line. And as you could see in subsequent slide, there would be a lot of merging of the slides because, as he said, things are still evolving and the front line and second line is still kind of not very clear at this point of time how we should categorize them. So just to start with, I have no financial disclosures. So as we know, in terms of histological classification of RCC, we have clear cell, which is the most predominant part. It's a 75% of all the kidney cancers we see. And the important germline mutation that is associated with it is VHL. So that is why the most of the angiogenic or TKIs that we have has been targeting the VHL. And then we have papillary type 1, papillary type 2, which together they have around 15% of RCC population, and then chromophobe. And definitely we have other variants which are unclassified. Because of the time constraint, today I would just like to focus on the data for the clear cells, because non-clear cell RCC is like a different topic in itself. So the objective that I have for today's talk is to discuss some of the second line and beyond treatment algorithm data, and some of them has already been discussed to some extent in the previous talk, because as I said, the front line and second line has been kind of, it depends what you use in the front line, and then that's how we decide on the second line. So next is like with all these new drugs coming in the past 5 to 10 years, this is a big question in the field of RCC, that how do we rationalize the sequences? Like, how do we sequence these therapies? And then the next relevant question in terms of personalized medicine is all disease progression the same? Like, if someone progressed on pazopanib, is definitely not the same if someone has progressed on IO combination or IO-TKI combination. So, and based on our experience, I can say that although we say kidney cancer because it arises from kidney, no two kidney cancers are the same, because they are very different at the cellular level, and that is what we are striving to understand. So, and take home message one is that what you use as frontline is very important. And one of the criteria that Amit also alluded to is this risk stratification. These are not perfect, but still it gives you some idea of how to categorize your patient. So one was this Mozart that developed in 2002 is a Mskcc risk stratification. So they stratified patient based on calcium, the hemoglobin level, LDH, if they're requiring systemic treatment within the first year of nephrectomy, and their performance status. So if you have none of those risk factors, then you have 0, and it's called good, stratified as a good risk patient. Then if you have 1 or 2 risk factors, that is, it's called intermediate, and 3 or more, it's poor risk. So before this TKI and IO era, the median overall survival was determined to be around 33 months for good risk, 17 for intermediate, and around 7 months, 6 to 7 months for the poor risk. This risk stratification was modified in 2009 when we started using TKI very heavily. And this criteria also incorporated few other clinical parameters like your WBC count and platelet count. So if a patient has anemia, hypercalcemia, if they're requiring systemic therapy within 1 year, poor performance status, thrombocytosis, and they have a absolute neutrophil count, which is upper limit, then they are considered as like poor risk. Like again, like treat more than 3 and 4. More than 3, it's a poor risk. 2 to 3, 1 to 2 is intermediate, and 0 is the good risk. So based on the TKI data, now the median overall survival changed because now we see favorable risk has it was like an ongoing, and with the intermediate we saw around 27 months, and the poor risk, the median overall survival increased like maybe by a month or 2. So we didn't kind of do very well in terms of with TKI with this poor risk groups. So definitely there are clearly limitation to both of this risk criteria, because they are, some of them are continuous and some are categorical variables, right? And then it doesn't take in account into threatening versus non-so threatening disease sites. Like if you have a brain mets, it's definitely not same as you're seeing an RCC patient with lung mets. So definitely this criteria are not taking these things into account. And also from the pathological standpoint, we know now from our MD Anderson experience that clear cell RCC with sarcomatoid or rhabdoid dedifferentiation behaves very, very differently and more aggressively than the regular clear cell variant. So, and then importantly, many patients in clinic with poor risk disease are not like clinical trial candidates. So therefore there is definitely a limitation when you're measuring the overall survival. So far, how do we think about, when we think about metastatic clear cell RCC? The pace of the disease is highly variable. And as you could see, if I can actually get my pointer to work. Okay. So this is, oops, sorry. So this is like a group which is a good risk, like they going in a speed of a marathon runner, right? Then we have this intermediate group. And then on top, we have this group which are poor risk, aggressive, or maybe having sarcomatoid or rhabdoid dedifferentiation. So, and all these people, actually different patient in different groups, they represent the progression and the pace of this disease is very, very different. And now, like with this 2 major class of drugs, I just want to take few minutes to kind of talk briefly about this 2 major drug class of drugs that we have. The one is the TKI, right? And the major TKI we have are our old generation sunitinib, sorafenib, pazopanib, and axitinib, which blocks this just the VEGF receptor, right? And then we have Bev, which we no longer use, which targets the VEGF. Then we kind of came with cabozantinib, which is a very strong TKI. And one reason that it was strong, because it actually affects multiple cell signaling pathways, namely CMAT, AXL, and as well as VEGFR. Now this other, the TKI that we have, lenvatinib, is mostly kind of targets at FGFR and VEGFR. And we know this cabozantinib can like also affect the nuclear translocation, etc. So now the other class of drug that we have is, for simplicity's sake, I'm just talking about anti-PD-1 and Emptor inhibitors. So Emptor is another cell signaling blockade pathway, which blocks the PI3 kinase Emptor pathway. And all this VEGF TKI or Emptor that directly targets the tumor cells, right? On the other hand, the immune checkpoint therapy, such as PD-1, they have nothing to do with tumor cells. What they do, they basically re-educate your immune system to come and kill the tumor cells. So T cells, when they get activated, so as a natural defense mechanism, they upregulate all the co-inhibitory molecules such as PD-1, CTLA-4. So tumor cells uses this interaction with PD-1 and PD-L1 to evade the immune system. So now by targeting this interaction of PD-1 and with PD-L1 and L2, and then CTLA-4 with B7 molecules, we can actually reinvigorate the immune system to come and kill the tumor cells. So they have like very distinct mechanism of action. So next, again, like with the introduction with this two major class of drugs, I mean, this is the most recent NCCN guidelines, and Amit also showed a version of it. So as you could see that, you know, one important thing to think in frontline, to look at the risk factors and then judiciously choose your frontline based on your pathology, based on the performance status, and overall the person's like lab parameters, etc. And then based on what you choose on your first line, then the second line, you can sequence it accordingly. And what I plan to do, that I plan to show the data of all the frontline preferred regimen and some of the new data with Cabo-Nivo and Len-Pam in the second line setting. So Nivo was the first immune checkpoint therapy that was approved in RCC in 2016. And I underline Pam Sharma because she was my mentor during my oncology fellowship in MD Anderson, along with Jim Allison, who discovered anti-CTLA-4. And they led this trial, BMS trial with Nivolumab versus everolimus in metastatic RCC, who has progressed after the frontline therapy. So here, what we saw that the median overall survival with Nivo was around 25 months, where with everolimus with 19 months. As you could see, this was not a big difference. Also, although you see a significant p-value, but what was important is this, like the tail, and that is what characterizes immune checkpoint therapy. That person who responds to immune checkpoint therapy, because it's not directly targeting your tumor cells, but it's re-educating your immune system. And if your immune system is kicked in the right direction, then you get a durable response. And that was what the main message of the IO trials that we saw in that period of time. So based on this data, we had Nivolumab approved as second line. But I also kind of want to like raise these questions that we noted in the forest plot. What was interesting in this, that when we looked at the forest plot, that favorable or intermediate did not have, I mean, they did show benefit, I mean, especially intermediate, but you can see this favorable group crossing the midline. But the group which actually derived benefit was the patient, where was the patient group with poor IMDC criteria. And although like there are a few other things that we saw, but you know, we have to take it with a grain of salt. The patient with previous one line of angiogenic therapy did better than more than two. It could be related to performance status or various other factors. And although it says that they did not see any benefit with patients who were more than 75 years old, but in our experience, like in my clinic, majority of my patients are 75 and older, and I'm seeing as good of a response in those patients as well. However, I do agree that with intermediate and poor risk, you see more benefited immunotherapy. And for favorable risk group, you always have to get the help of a TKI. So another question was that how do we select this patient? And this is like a burning question in the field of immunotherapy, that what is the predictive biomarker we should use? And a big focus was on PD-L1 expression. We still do it, but we don't use it to select our patients. So the clear answer that should we select patients only with a high, PD-L1 expression? And the simple answer is no. And this is based on this data as well, that patients even with low PD-L1 expression also showed the similar benefit as patients with high PD-L1 expression. So next trial, the Kabusine trial, I want to talk about, which led to cabozantinib as approved regimen for first line as well as second line. So this is the, this is the first is the Cabo versus everolimus trial that led by Mozart, and it is again in 2015. That is the second drug that came for second line, where we saw a median significant difference in the median PFS in Cabo when compared to everolimus, where Cabo we saw around 7.4 months, everolimus it was around 3 months, 3 to 4 months. And then what was interesting was that we saw a clear overall survival difference between Cabo and everolimus, where median OS was 21.4 months, everolimus was 16.5 months. So the next trial that I would like to quickly talk about is the everolimus and lenvatinib, that is in the second line, is this Lancet Oncology paper, where they kind of looked at the median PFS between len-everolimus, len alone, and everolimus. And as you could see, like based on the Cabo-everolimus trial, the PFS kind of seemed a little bit different, and this might be because of the selection of the patient population. Anyhow, we did see a median overall survival of, median PFS of 12.8 months with len-everolimus. But in my experience, I always keep len-everolimus for third line or beyond, because this is definitely not an easy regimen to tolerate, and we always need to like dose reduce it. So now I would quickly want to talk about few of the newer trial that coming up and possibly leading to the approval of Cabo and Nivo, which has already been approved in the front line, is this Checkmate 9er trial. And as you could see that they had mostly patients with the intermediate and poor risk, but they also included around 22% of patients were with the favorable risk categories. So this published in New England Journal of Medicine. And here what you see that, you know, with the overall survival, that definitely Nivo-Cabo did much better than sunitinib. But it would be interesting to see if we want to kind of compare head to head, if what we see the difference between with Nivo alone or Cabo alone. So in my practice, I have been using this combination even before its approval. And the way I have been thinking about that, if I have a poor risk patient, I use Ipi-Nivo in the front line, then Nivo maintenance. And if I see any signs of progression, then I kind of add Cabo with it. And I did see a very good response with that strategy. And as I said, I have been doing it even before this approval. And now it would be like easier to use this regimen from the insurance standpoint. So the next kid on the block, or next combination in the block, is the len-pam. And I don't want to spend too much of your time because my previous speaker did talk about the clear cell, this clear trial data. And this was published in April 2021 in NEJM from Tony Sherry's group, where they kind of combined len and pam and compared with everolimus for advanced RCC. And as you could see, they also had 31% of favorable risk, 59% intermediate, and 9% of poor risk patients. And when they compared len-pam with len-everolimus and sunitinib, you clearly see advantage of using len-pam over len-everolimus or sunitinib, both in the median PFS. However, like looking at the overall survival data and the toxicities that we normally see with lenvatinib, I always like reserve it for later lines, like third line and beyond. So this is like a summary slide of looking at the objective response, that with len-pam, we have around 71%, len-everolimus 53% that we have been seeing, and sunitinib with 36%. And definitely the CR and PR were more with the Len-PAM combination. And some of the adverse effect that you could see that, like around 84% of patients did have some kind of grade 3 or more toxicities. And mostly we see with hypertension and diarrhea, etc. But although this trial hasn't highlighted decrease in appetite and proteinuria, these are like an edema, these are like few big issues that we clinically see with lenvatinib. So I kind of also quickly outline some of the new stuff that is in Horizon. So this is like phase 1/2 study has been published in GU ASCO this year, and Eric Jonas from MD Anderson, he led the study. And we have clinical trial at this point of time going on with the oral HIF2 alpha inhibitor, like belzutifan and few others, like Arrowhef, because as I mentioned initially that VHL, right, that is one germline mutation that you see in 75% of clear cell RCC, which eventually lead to less hypoxia, HIF factors upregulation, leading to disease initiation and progression. So we are like looking at this data very eagerly to see what kind of response we see in this phase 1 and 2 study, and eventually with combination. So just to kind of briefly go over belzutifan, it basically inhibits they selectively inhibit HIF2 alpha, and we have also trial with patients with VHL disease with this particular drug. So far, the data is what we have is this is the plot that we are kind of seeing with this for the duration of treatment with clear cell RCC, and the objective response like around 25%, 31%, and 24% in the intermediate group. Although we didn't see any complete response so far, but we did see partial response even with the poor and intermediate risk categories. So that is something we are eagerly kind of waiting to see what we find with this drug. And now to kind of bring a little bit into the personalized medicine to talk what else is in the horizon. And in this year, there are like 4 papers that came out in Cancer Cell that talked about looking at the progression of RCC. And one thing with what we have seen, that the T cell exhaustion, which basically the T cells are exhausted, are not functional anymore to kill the tumor, they increase over the course of disease, especially metastatic disease, and M2-like, that is a suppressive disease, a suppressive myeloid cells increases. So as you could see that when the disease is advanced, your microenvironment is not as conducive to take care of the cancers. And this is a summary slide just to kind of show that. And that is also a reason when even if we are using immune checkpoint therapy, sometimes because you have such highly dominant myeloid population there, that just by single agent immune checkpoint therapy, it might not be enough. And that is something we have been seeing clinically. So what else we can do? So this is an area of research in the field as well as in my lab, like can we target other agents? What can we see beyond immune checkpoint therapy, and what are the predictive biomarker we can use? Can we actually change these myeloid cells, those bad guys, into good guys by reprogramming them through epigenetic drugs, and for which I have clinical trials going on. So those are the things that we should closely watch for while we are kind of treating our patients, because although we have moved a long way in last 10 to 15 years, but I feel we are still kind of touching the tip of the iceberg. So now for all the fellows and everything, so this is how I always used to think that I cannot pay attention to all the data. So, but when I do, it's always a take-home message, right? So what is my take-home message? So the this treatment has really evolved since 2016. Now we have so many targeted agents, right? We have cabo, we have lenvatinib, we have this IO option, this combinations. So how do we sequence them? So one thing is critical, and I would highly encourage to all the fellows and residents who would be moving to this field, try to understand the mechanism, because that is very, very critical to decide how we should go. Like, we should read the patient, look at their clinical parameters, and then try to understand that what's going on, so that we can actually judiciously sequence their therapy. So I don't want to go more over this mechanism because I have done it previously. So some of the discussion endpoints, and Amit also alluded to it, that when do you think, when you would favor IO-IO? Someone with a high performance status, young person, sarcomatoid differentiation, where I'm really trying to get a high CR rate, right? Because we want a durable response and we have a longer treatment-free intervals. So then toxicity is definitely less, but if it happens, it is severe and refractory, and that is something we have to keep in mind. So definitely I don't want someone who are hospitalized with a PS of 3 to get an IO-IO combination. And we do have data from our MD Anderson group that patients with sarcomatoid differentiation, they respond very well to immune checkpoint therapy. So when do favor TKI IO? Someone with favorable risk or low intermediate risk, because they do have higher objective response rate. And we do see a quick response and a greater depth in response. And toxicity is manageable, but it is very chronic. And this is good across all the risk groups. So just quickly get into this IO therapy related side effects, because we use so much of immunotherapy, and because MD Anderson has been leading the ipilimumab in different trials, so we have been using IPI and different combination as standard of care, as well as in clinical trials. So we do see a lot of immune-related side effects, and we are trying to develop a program both from basic science as well as clinical, that how do we understand this therapy side effects better, and how do we treat them. So as you could know, that this is basically reinvigorating your immune system, right? So it can attack any of your body part, your brain, your eyes, the hormones, lungs, liver, kidney, skin, anything, you name it, and you can see those side effects. So when you treat them, someone with IO, be very vigilant about it. Any diarrhea more than 3 times, it's not a TKI that you will give a Lomotil. Bring them, assess those patients. If needed, they need to get a colonoscopy, etc. So because these things can actually lead to serious side effect and resulting in death. So, and we are trying to develop algorithm where we are trying to minimize chronic steroids, because what has been happening, this patient has been on chronic steroids, you are seeing opportunistic infection. So before cancer can kill them, the side effects were killing them. So we are trying to develop infliximab, toci, rituximab, and plasmapheresis, etc., the different algorithm to treat this immunotherapy related side effects. And some thoughts for sequencing, and I have a few more slides, that, as I said, like what you choose in frontline is very crucial, because you see the highest response rate in the frontline, which comes down eventually in the second line and third line, right? And if you want to add IPI, I always suggest using IPI as frontline, because with all the trial that coming, like Titan, Omnivore, and HCRN, these trials that they have shown that there's very modest improvement of a response with adding IPI in the later line therapy. And you can always like continuing IO in the later lines, like lenva pembrolizumab, but that is like, I can understand in the Indian setting, like IO is expensive. So that also something we have to think when we are continuing IO in the later lines of therapy. So this is how I approach my different lines, So if I have a good risk patient who's have favorable sites of disease, or don't have many unfavorable comorbidities, I look at their lesions. If someone has a kidney lesion, which was, say, taken out in nephrectomy 10 years ago, now coming up with a lung lesion, I always consider local therapy. Can we actually do a SBRT or a resection and do a metastatectomy and actually have them longer interval, right? Then if I have to choose, I still use pazopanib. I'm not a big fan of sunitinib because of the side effect, because I think pazopanib, at least in this population I treat, they tolerate better. Or I would think about TKI or IO. With intermediate risk group, I always would consider TKI plus IO or nivo-ipi. And when I have this aggressive disease with liver, bone, brain, and young physiological age, I go for ipi-nivo, but there are some caveats. If you see a lot of burden in liver, I always like to get a TKI on board just for a strong response. And we have a lot of data in immunotherapy and liver metastasis, which are like a negatively correlated. So those are the few thoughts when I kind of think about my patients, depending on the risk factors. And how do I sequence them? So especially the poor risk or sarcomatoid, if I'm doing a nivo-ipi, and if I see some good response, we have data that axitinib also can hold the disease for some time. So definitely I try axitinib if I have this window. If I don't, I go cabozantinib. Because another food for thought is like, if you use axitinib as an intermediate, you can go to cabozantinib. But what happens if you use cabozantinib and the patient is progressing? Axitinib can barely hold the disease because cabozantinib, as we know, hits different pathways, right? So therefore, like patient who has progressed on cabozantinib, using axitinib is basically you are treating yourself, not the patient. You do not see too much of response. So if I use TKI and IO as a first line, then you can consider, nivo-ipi. But as I said, the nivo-ipi based on the Titan data, it only has 10% chances of rescuing. I would rather go like cabo. And then I go to like lenvaeverolimus, now like len-pem, and maybe then hospice. And what I'd like to do normally, if I have after frontline or between this line, I like to like sequence them with clinical trials if we have good clinical trials available. So finally, I would like to thank you all for your attention, and I would be happy to take any questions, or maybe we will have questions at a later time point. Okay.
Thank you,
should I
Sangeeta.
keep it?
Dr. Sangeeta, it was a wonderful talk with very insightful points for practice. Maybe we have time for 2 questions. Dr. Aparna Shivasa wants to ask, is there any data on atezolizumab?
We have not on atezo yet, like there are trials going on, but we have data with like Nivolumab, like Javelin study, right? So far, because there is no like data available at this point of time with atezo, I haven't been using that, but I know Genentech has been kind of working on it. So the second question, which risk group will benefit more with IO? Yeah, so the way I kind of think when I think about IO or IO-TKI, if I have a young patient, okay, with a good performance status and very aggressive disease, I do IO first, especially if they don't have like a huge visceral metastatic burden, right? So I do IO-ipi nivo first, and then I continue with nivo, and then if I see it's progressing, then I bring cabo. So because again, as I said, that it's very important to understand the mechanism that if you want a quick response, the cabo is good. Then you should definitely consider cabo with nivo as frontline. But if you have that time period, ipi actually works better than Nivo. It's also because like I have my own personal preference, because when you try to understand the immunology, then what Ipilimumab does, it actually primes your immune system. And that response is much more durable than anti-PD-1, because anti-PD-1, what it does, it like rescue your exhausted T cells to be more functional. So therefore, like if you really want to prime it, and I have like research data, EP does a better job than anti-PD-1 alone. So yes, I prefer IO if I can do it, but if I have other clinical parameters that I need to consider, then I consider Cabo-Nivo. Recurrent carcinoma, kidney, single lung, post SBRT, further treatment or follow-up? Yes. So suppose you have a patient who had nephrectomy many years ago, you think they have an indolent biology, and you see one lung lesion. You did SBRT, but then I do follow them every 3 months with CT, chest, abdomen, pelvis, and lab. So definitely we do that. And one thing, just we can discuss that later as well. Few clinical caveats that I didn't have time to mention is like renal cancer, which goes to pancreas, right? Normally we always kind of tend to think that, oh, pancreatic cancer deadly, but we don't understand the biology yet. But kidney cancer, which goes to the pancreas, has very indolent biology. In fact, in my practice, I have like 3 patients now with multiple comorbidities, and they have lesions in the pancreas. All I'm doing is like observing this patients, with active surveillance. I scan them every 3 months. And one of the patients, it's been three years now. I'm just watching him. So that is also something important, like what is the site of metastasis? Can I do that in liver? No. For liver, you wanted to treat them like yesterday, right? But so those are the kind of some of the clinical caveats you have to understand when you're selecting these patients, but you definitely have to follow them every 3 months with CT, chest, abdomen, pelvis, and labs. Yeah. So yes, so those are I think the chat questions I had, and later on I can take the other questions.
Thank you. Next we have Dr. Vishwanath, who is a consultant medical oncologist in Apollo Hospitals, Bangalore. He will talk on role of Nivolumab in metastatic RCC. This is a BMS sponsored session.
My slides visible?
Yes.
Okay. Thank you so much, Dr. Santosh. And after those 2 very insightful talks from Dr. Amit Rauthan and Dr. Sangeeta Goswami, I will be talking about the role of Nivolumab in RCC. I'm sure there's going to be a lot of overlap, but I've also tried to get in some new information. So Dr. Sangeeta has gone through this in great detail. So there is a rationale for immunotherapy in advanced RCC. So spontaneous remissions attributable to the immune system are reported. And because RCC is one disease where there is extensive immune cell infiltrates, and several immune escape mechanisms have been reported in advanced RCC. And immuno-oncology, as we know, it's like a rapidly growing field. And so basically it harnesses the body's own immune system to fight cancer. Of course, there have been a lot of unmet needs in these RCC patients with respect to treatment. One is the long-term survival. So we're looking at cure with certain potential cure with certain regimens, quality of life, which is an important endpoint, and achieving complete responses. And like Dr. Amit Rauthan mentioned, most importantly, the durability of response. So I think this has been alluded by the previous speaker. So we have this IMDC Heng criteria, which came in the TKI era, which includes 6 criteria. And then depending on the number of criteria, it again favorable, intermediate, and poor risk. And currently, as we are selecting first-line treatment for metastatic RCC, we're seeing that at least 75 to 80% of the patients at least have one risk factor, and therefore they would be classified as intermediate or poor risk. And that's one of the reasons we have only a quarter of patients being classified as favorable risk. So based on this, like Dr. Sangeeta mentioned, there is definitely the survival comes down as the number of factors go up, and based on whether it is favorable, intermediate, or poor, the survival goes down as it is as the factors increase. And this, like Dr. Sangeeta mentioned, there are a lot of good guys and bad guys in the tumor microenvironment. And like she said, the CTLA-4, it acts on the peripheral lymph nodes. And what it does is it causes activation of the NK cells and causes anti-tumor response. And then we have the PD-1 blockade, which causes the inhibition of the Tregs and the effector T cells, and then causes the anti-tumor response. Hence, it's very synergistic. So that's one of the reasons, the biological rationale of combining PD-1 with the CTLA-4 antibodies. So there is also this rationale for combining the VEGF and the PD-L1 and the PD-1 inhibition. So we know that there's elevated VEGF, which inhibits the dendritic cell maturation and causes immunosuppression. And then we also have when we inhibit the VEGF, it may reduce the number of Tregs and tumor-invading myeloid derived suppressor cells, which are kind of the bad guys. And hence this anti-VEGF therapy may act as a primer for better effect when we combine with PD and anti-PD-1 or PD-L1 blockade. So going on to what Dr. Amit Rauthan did mention. So first line RCC, we have this Checkmate 214 trial. The inclusion criteria included patients with advanced RCC, clear cell, good performance status, over 1,000 patients, and most importantly, brain metastasis excluded, and patients were stratified based on the IMDC prognostic score, and then region if it was US, Canada, or rest of the world. And the patients were randomized to Nivo plus EP for 4 doses, followed by Nivo every 2 weeks. And in this arm, the patients could discontinue after 2 years of study treatment. And the other arm was sunitinib, 50 milligrams once a day, 4 weeks on and 1 week or 2 weeks off. And we have the primary endpoints, the overall response rate, progression-free survival, and the OS in the intermediate and poor risk. And secondary endpoints included these factors in the intent to treatment population. So what we can see here is that, like we previously mentioned, that the favorable risk included 23% of the patients, and 77% included the intermediate and poor risk. And what is important to know is that this was the initial trial which showed a double-digit CR. And you can see that there's a 10% CR, and the overall response rate was 42% as compared to 25% in the intermediate and poor risk as compared to sunitinib. So you can see that impressive CR rates with this regimen. And this is something which was told by Dr. Amit Rauthan, that this is the 48 months, the latest update. As you can see, it's nice to see that the curve starts separating at 24 months. And what is nice and interesting to know is that it is kind of plateauing, and that's even at 54 months. And there is a wide separation of curves in the progression-free survival and the hazard ratio of 0.89. And what you can also see is that in the intent, that is the intent to treatment population. And what is it? It's more impressive hazard ratio in the intermediate and poor risk, which was the primary efficacy endpoint. And this is the overall survival. Again, it's important to know that in the intermediate and poor risk, if you look at it, at 48 months, 50% of the patients are actually alive. That makes it like 1 in 2 are actually alive. And that is what we're looking at, durability of response with this adding of EP to Nivo. And yes, the previous speakers did mention that there's no OS benefit because we know that favorable risk do well with TKI. That's probably one of the reasons why this is happening. We have overlap of curves when it comes to combining it with sunitinib in case of favorable risk. So also something which is important to know, that patients, around 59 patients had a complete response. And you can see that median time to response in complete responders was 2.8 months. And what you can also see is that 34% of those patients are actually still on treatment, and patients off treatment never received subsequent systemic therapy. 47% of these 59 patients, actually, if they did not receive any subsequent treatment, also had a complete response, which was ongoing. And so that is something which is important. So you have a lot of patients who are actually having complete response, and they're actually having ongoing response, even if they have stopped therapy. And the quality of life is also an important criterion. And what you can see here is that the Nivo plus EP, as compared to sunitinib, the quality of life is good. And that's probably one of the reasons why the dosage of EP in case of RCC is 1 milligram per kg, but in case of melanoma, it is 3 milligrams per kg. That's probably one of the reasons why I would think that the quality of life is actually maintained. And the toxicity, if you see the grade 3 and grade 4 side effects, it's very pleasantly surprising to see that these grade 3, grade 4 side effects are actually coming down with time. And this is again the question. This was the ASCO publication presentation recently, the keynote 426, the PFS and the intent to treatment arm. And what you can see is that Dr. Amit Rauthan did mention, so there is separation of curves, as you see, 48 months, 54 months, there's wide separation of curves and this plateau in the progression-free survival. What is kind of disappointing to see is, I know it's early days, maybe things may change. And this hazard ratio difference may also be because we are looking at different time points. If you looking at 36 months, so you're looking at a hazard ratio of 0.68, but what is kind of coming down is the PFS. The curves are dipping. So going on to the Checkmate 9ER trial, again, the inclusion criteria included patients with the clear cell component, any IMDC, and based on that, they were risk stratified. And of course, like Dr. Sangeeta mentioned, PDL1 is not very important in case of RCC. That is what trials have shown. And patients were randomized to Nivo plus Cabo. Cabo as a single agent would be 60 milligrams, but when it's combined with Nivo, it will be 40 milligrams. And the other arm was sunitinib, the standard of care, 40 milligrams, 50 milligrams, 4 weeks on, 2 weeks off. And the primary endpoint was PFS, and the secondary endpoint was OS, overall response rate, and safety. So here again, I would like to mention that around a quarter of the patients were actually in the favorable risk, and around 74% of the patients had lung disease, lung mets. And again, what you can see here is this is the intent to treatment arm. There is a wide separation of curves, significant improvement in the PFS at 18 months, and also a good hazard ratio in the overall survival. And what you can see is, again, at 18 months, things are much better with the Cabo plus Nivo arm. And the response rate, like Dr. Amit Rauthan mentioned, in his study, it was around 60%. This is what we see around 55%. And the complete response rates were not very different from the Checkmate, the Nivo plus EP arm study. It's close to 10%. And the median time to response, this is something when we add TKI, like Dr. Sangeeta mentioned, you want a faster response, maybe IO plus TKI is the way to go, because 2.8 months you're trying to achieve a response. So again, looking at the different risk groups, favorable risk, yes, the curves are separating, but in the PFS, but if you see the OS, it's a significant overlap with sunitinib. But if you look at the intermediate risk, again, not much of separation of curves in the OS. But if you look at poor risk, definitely the hazard ratios are very significant, 0.36 in the PFS and 0.45 with the overall survival. Definitely in poor risk, Cabo and Nivo is here to stay. And if you look at the adverse effects, diarrhea, hand-foot syndrome, hypotension, and fatigue were the main side effects. But other than that, it's been a decently well-tolerated regimen. And like Dr. Sangeeta mentioned, MD Anderson, there was some study on sarcomatoid histology. Here again, in this study, they looked at sarcomatoid histology. And if you look at the PFS and the OS, look at the hazard ratios. 0.42 and 0.36 of the PFS and OS respectively. Wonderful hazard ratios. Maybe for sarcomatoid histology, this is the way to go. This is the $1 million, I would say, the slide. And if you look at the Checkmate 214, Keynote 426, the Checkmate 9ER, and the clear study details. So what I would like to look at it critically is, if you look at the Checkmate 214, 55 months of median follow-up. And what is the clear data? It's very early days, 27 months. And even if you look at the other data, it's around 23 months for Checkmate 9ER, and it's 42.8 months for the Keynote 426. And what is the median OS with the Checkmate 214? Median OS is not reached. Of course, it's not reached with the clear data, but we are looking at very early follow-up. And also look at this favorable risk. We are looking at around a quarter of patients who have favorable risk in case of the Nivolumab trials, but look at the Keynote 426, around 32% of the patients actually had a favorable risk. And even if you look at the clear trial, it was on 31%. Was that the reason why the clear data was so impressive? And maybe that was the reason why the overall response rates was 71%, much more than any of the trials. Maybe because of this favorable risk. I would probably leave it to our experts to answer during the question and answer session. But finally, I think with a couple of years to go, maybe 2 years later, I would probably look at it this way. Very similar cartoons. I mean, all of them very similar, but maybe subtle changes. We may be in a situation where they're all interchangeable, and we may be able to use any of these drugs. And depending on the depth of response and the how fast we need the response, maybe we might combine IO-TKI or IO-IO combination. So a few words about Nivo plus EP salvage. Dr. Sangeeta did mention about this Titan study, where they looked at patients who were untreated or who had one prior line of TKI therapy and received 8 cycles of Nivo once in 2 weeks, the standard dose of 240 milligrams. Those who had a CR or PR continued to have received the Nivo monotherapy, but those who had a stable disease or progressive disease received the rescue Nivo, the EP, once in 3 weeks, 2 doses, and again further stable disease or progressive disease, 2 more doses of EP rescue. So what you can see here in the first line, the median OS was not reached. Second line, it was 20.2 months. And what is also, like Dr. Sangeeta mentioned, there was a 10% benefit. And I would say it's actually, yeah, 10% benefit in the overall response rate, 22% to 32%, which is not too bad. Maybe considering EP again, but this is a phase 2 trial. I wouldn't, maybe larger studies are required to maybe make such a bold analysis. So this has been mentioned by the previous speakers. I will just skip this. So just based on Nivo, if the patient is how to sequence therapy in the second line, if the patient is EP naive, maybe if the patient, if you want to add EP with Nivo in the second line, and if the patient has had a prior VEGF therapy, and a patient is IO naive, you can add Nivo, and there's some early data for Nivo plus EP as well. So what about second line RCC? I think this has again been told by the previous speaker, the Checkmate 025 trial. What I would like to mention is this is again Nivo versus everolimus in clear cell, good performance status, and no CNS meds, and no glucocorticoid use. This is the long-term follow-up. And here you're looking at 60 months. And Dr. Sangeeta did show us the 2015 NEJM article and publication. And what I'm showing you is the extended follow-up of 60 months. What you're seeing here is Nivo showed a median OS of 25.8 months. This was what was shown by Dr. Sangeeta, and everolimus of 19.7 months, and the hazard ratio of 0.73. But a quarter of the patients are actually alive at 5 years as compared to 18% with the everolimus arm. And what was the response rate? The response rate was around 22.9%. Mind you, you're looking at the second line, so 22.9% in the second line seems to be decent response rates. And of course, everolimus, we are, like Dr. Sangeeta did mention, that everolimus and lenvatinib is a very toxic combination. So everolimus is something which is difficult to deliver. So you're seeing good quality of life with the Nivo arm as compared to the everolimus arm. So a few words about the non-clear cell histology. So Nivo has also been looked at in the ASCO, latest ASCO. So a phase 2 trial in non-clear cell histology, advanced or metastatic non-clear cell patients, measurable disease by RECIST 1.1, 0 or no 1 line of prior therapy, systemic therapy, and the patients are all IO naive. And these patients received the same, the standard regimen of cabozantinib 40 milligrams once a day, plus Nivo 240 milligrams IV every 2 weeks, or the conventional, or the dose of 480 milligrams once in 4 weeks. And the primary endpoint was overall response rate, and the secondary endpoint was PFS, OS, and safety and tolerability. So what you're seeing here is the cohort 1 had 40 patients, which included papillary, unclassified or translocation associated RCC, and the cohort 2, which included only 7 patients, included the chromophobe RCC. And what you see here is a 12-month PFS of 52.8%. And you can see that the median PFS was 12.5 months, and the median OS was 28 months. And like you see here, only except the chromophobe, all the other histologies did benefit with this particular regimen. So Nivo plus Cabo does show a promising efficacy in metastatic non-clear cell RCC patients, and the adverse effects in non-clear cell RCC were consistent, and it was very similar to clear cell RCC. And the chromophobe, there was no the benefit, so there was no objective responses in the cohort 2. So Dr. Amit Rauthan did mention a very nice and interesting case of brain metastasis. This is from the recent ASCO. So this was the Checkmate 920 trial, which is a prospective US community-based phase 3B or 4 trial evaluating Nivo plus EP in 4 cohorts of patients who are typically excluded from the registrational trials and have an extremely high unmet need. So if you look at cohort 1, it included clear cell with good performance status, 106 patients, Nivo, the dose was a little different, plus EP once in Q8 weekly, alternating with Nivo 480 milligrams Q8 weekly, staggered every 4 weeks. And the cohort 2 included non-clear cell histology, good performance status, again a different dose of Nivo plus EP. And the cohort 3 included patients with clear cell as well as the non-clear cell with non-active brain metastasis, good performance status. And the cohort 4 included again patients with clear cell and non-clear cell RCC with or without brain metastasis, but the patients had a poorer performance status. And all these 3 arms were followed by Nivo single agent. So what you can see here is that the median PFS was 9 months and the median OS was actually not reached. And when you look at this overall survival at 24 months, it's around 63.2%, which seems to be impressive, especially in patients with brain mets. And if you look at this investigator assessed confirmed overall response rate by RECIST 1.1, 32%, which seems to be a decent response rate. And if you look at the median duration of response, it's around 24 months. So this is what I would like to conclude my thoughts on the Nivo EP and Nivo Cabo, the entire thing about Nivo data. So Nivo plus EP in the first line seems to give durable responses even in patients who have discontinued treatment, like I showed the swimmers plot. And the Nivo plus Cabo seems to be a viable option to consider in the IO plus TKI space, especially when you want a faster response. A depth of response is required in the first line setting. Salvage EP, yes, Dr. Sangeeta did mention that very modest responses. Yes, it's very early data, but seems promising, needs more robust data. And Nivo shows responses even in non-clear cell histology and even in patients with brain mets, but of course, more data is required. Thank you so much for a patient hearing.
Thank you, Dr. Vishwanath. You very nicely detailed the data with regarding Nivolumab in RCC, both in the clear cell setting and the non-clear cell patients. So going on to the next talk, we have a panel discussion with our expert speakers. It will be moderated by Dr. Linu Jacob, who is the medical oncologist and a senior professor at Kidwai Memorial Institute of Oncology. Over to you, Linu, sir.
Hello. Yeah, good evening to all.
So can you make it a slideshow?
Yeah, so good evening. So after listening to all the talks, what you are supposed to do in the first line and then subsequently second line and beyond the second line, I think what we will do is that in the next 15 to 20 minutes, we will try and solve some case scenarios. We will have a simultaneous poll as well. I think all the answers are correct, so there is no problem. So everybody can attempt. And then subsequently, after taking the poll, we will take the inputs from the experts. So it is a pleasure listening to Dr. Sangeeta as well as Dr. Amit speaking on renal cell carcinoma, both the first line as well as the second line. So we'll go to the first case. A 58-year-old man presented with hematuria and urinary obstruction. CT abdomen showed left renal mass 13.3 into 12.3 into 10 centimeter, and chest CT scan showed a 1.5 centimeter left lung nodule. So he underwent a left radical nephrectomy and the left lung metastatectomy. And the histopathology turned out to be clear cell renal cell carcinoma. So in view of the lung mets, stage 4 oligometastatic disease, underwent complete resection of both the primary as well as the metastatic disease. So this is a case of M1 with no evidence of disease. So here I will launch the poll. My question would be, what would be your preferred treatment? So I think you can start giving the answers. So this is for an M1 with no evidence of disease. What would be your choice? Is it observation? 1 year of adjuvant sunitinib, 1 year of adjuvant pembrolizumab, or a combination of axitinib plus pembrolizumab? So we'll wait for about a minute. So because only 8 have voted, I think there are 40 plus participants. So as I told, there is nothing called as right or wrong. everybody can participate, and then subsequently we will have a discussion. Are you able to submit your answers, so it is showing that the poll is closed?
Sir, somebody has commented saying that poll is not visible actually. Somebody in the group has.
So I've launched it again. Please try. Yeah, I think now the responses are coming. I think still we are not halfway through, only 18 out of 40. Okay, so we'll end the poll and show the results. So I think majority have voted for 1 year of adjuvant sunitinib. 33% of the respondents would go for 1 year of sunitinib. 28% are for observation. 22% are for 1 year of pembrolizumab, and 17% have voted for a combination of axitinib plus pembrolizumab. So I think we'll take the inputs from our esteemed speakers. Dr. Amit and Dr. Sangeeta, you are free. Dr. Vishwanath, anybody can pitch in.
So as you said, there's really no right or wrong answer here. I would say sunitinib 1 year could be used as per we have the data. Only thing is, no one was very impressed with it, because even after 5 years, we don't have OS data, the overall survival, though we did say we had PFS advantage. So considering the toxicity of sunitinib, we are really not very impressed. The 1 year of pembrolizumab data, which we saw this year, is quite impressive. Again, it's only disease-free survival data. So we don't really have the overall survival data from there, but that also looks very impressive. And I'm hoping that 1 year of pembro will show up a better result in terms of adjuvant setting. Incidentally, the 1 year of pembro trial, the keynote trial, actually had this group of patients also. Though it was an adjuvant trial, there were a few patients who had resected, had got M0 and then received pembrolizumab, exactly like your patient. So it will be an interesting read.
Yeah, Dr. Sangeeta, your valuable inputs, please.
Sir, I think she's just gone offline. I think there's some connectivity problem.
Fine. So I think trying to answer this particular question, as we all know, we had many adjuvant trials with sunitinib, pazopanib, sorafenib, and axitinib, out of which the extract trial was the one which showed a DFS benefit. There was no improvement in the overall survival. And these patients were mainly non-metastatic patients, either T3 and above or node positive and above. Such patients were randomized in the extract trial to sunitinib or to placebo, and there was an improvement in the disease-free survival. So none of these studies included the metastatic patients who underwent resection and then who had a M1 and no evidence of disease. And as Dr. Amit had pointed out, this year, this study was presented, the abstract was presented of adjuvant pembrolizumab, the Keynote 564 study, in which patients with M1 with no evidence of disease, so patients with histologically confirmed clear cell renal cell carcinoma and nephrectomy less than or 12 weeks prior to randomization and no previous systemic therapy. So they were stratified by M0 versus M1, that is no evidence of disease. So this particular adjuvant pembrolizumab study included both stage 3 patients as well as stage 4 patients completely resected with no evidence of disease, and they were randomized into pembrolizumab and placebo. And again, the primary endpoint was disease-free survival, and we cannot comment on the median survival because in both the arms it was not reached. And if you see the p-value, the DFS, the disease-free survival, the median DFS, the difference was significant, whereas in the median overall survival, as of now, with the current follow-up, it has not reached the pre-specified significance level. The other studies which are probably happening in this particular setting, that is the M1 NED, in addition to the Keynote 564 studies, are the IM Motion, where atezolizumab is being compared with placebo, and the Prosper renal cell carcinoma, that is where the nivolumab is being compared with observation in pretty much the same group of patients, including metastatic patients who have undergone complete resection. So that was with regard to the case 1. So let's go to another case scenario. A 66-year-old female diagnosed with right renal cell carcinoma underwent radical nephrectomy. The histopathology came as clear cell renal cell carcinoma. And she was observed, and a year later, she developed lung and skeletal metastasis. Her performance status was good, relatively normal laboratory values, and no comorbidity. So basically, this here is a patient of metastatic clear cell renal cell carcinoma and an IMDC of favorable risk. So the question here is, what would be your preferred treatment? I think Dr. Amit had spoken extensively on this. So I will launch the poll again. So what would be your choice? Would it be a sunitinib, or whether it would be a combination of axitinib plus pembrolizumab, ipilimumab plus nivolumab, lenvatinib plus pembrolizumab, or cabozantinib plus nivolumab? So all these are drugs or combinations which have been approved in the first line setting. So here you have a patient who's having an IMDC favorable risk metastatic renal cell carcinoma. So request all to participate, as I told, and as Amit has also supported me, telling that you answer any of these choice, you can still argue and then substantiate. So just ignore the second part of it where it is written as untitled question. I think some poll is happening there as well. I do not know whether it's because of the technical issue. So the choice is either sunitinib, axitinib, pembrolizumab, ipilimumab, nivolumab, or lenvatinib, pembrolizumab, or cabozantinib plus nivolumab. So we are almost in 1 minute, 1.5 minutes into the polling. I think we'll end the poll and we'll share the results. So I don't know what to do with the untitled option. One has come as the maximum poll. Santosh, is there an issue with this? Maybe 75%?
I think there is some problem. One of the participants just told that they are not able to poll. They just messaged. So there must be a technical issue, sir.
Okay. Okay, so if you concentrate on the upper part, I think 31% of the people have voted for axitinib and pembrolizumab, 31% have voted for ipilimumab, nivolumab, 19% for lenvatinib, pembrolizumab, and 19% for sunitinib. So is Dr. Sangeeta back? Maybe we can take her inputs.
Sure, sorry, I got kind of kicked out of Zoom. Can I go back to the question, please, because I didn't see the question. I can also like to give like 2 comments on the previous one. I don't know what we kind of discussed on the first question. My take would be observation. if the patient do not have any sarcomatoid dedifferentiation or any other stuff, although we have the START trial data and the adjuvant pembro data, but considering the toxicity and the benefits, because both of them didn't show any OS benefit yet, so that's why on that one my take would be observation. XC pembro is not approved in the adjuvant setting. Sunitinib and pembro are correct if you want to do that, but considering all the side effects and no overall survival benefit, and especially if they don't have any sarcomatoid or rhabdoid dedifferentiation, I would observe these patients.
I think I fully agree with that. I think that is what most of us do, especially in the metastatic setting with oligometastatic disease where the complete resection has happened. Most of the patients are put on observation. And I think that holds the true even in spite of the extract trial, even for stage 3 patients as well. We are currently not giving adjuvant treatment, adjuvant sunitinib.
Okay. If you could show me the second question, that would be great.
The second question was of a patient of metastatic clear cell renal cell carcinoma with an IMDC favorable risk. So you want me to read the question again?
No, I'm good. Okay, perfect. Got it.
It's metastatic clear cell carcinoma with IMDC favorable risk. So the options which were given us: sunitinib, axitinib plus pembrolizumab, ipilimumab plus nivolumab, lenvatinib plus pembrolizumab, and cabozantinib plus nivolumab.
Sure. So, do you want me to kind of now?
Yes, you can give your input. So 50% of the patient, 50% of the responders have voted for axitinib, pembrolizumab, and 50% for ipilimumab, nivolumab.
I would not do ipi-nivo because it's favorable risk, right? So because it's favorable risk, so I would not kind of give ipi-nivo. XC pembro you can consider depending on other issues, but normally this kind of patient also does well with single agent TKI. I'm not a big fan of sunitinib. I do pazopanib, but that's a personal choice in terms of your side effect profiles. But either both are equally right. You can do XC pembro or a single agent TKI, but I would not do ipi-nivo on a favorable risk patients with the criteria, clinical criteria that has been shown.
Dr. Amit?
So I would kind of favor, so you have multiple lungs, so it's not really, so I would favor any of plus T combinations. So, but again, there's really no preference between the IO and TKIs, though we keep comparing the 3 trials, we really cannot say which is sort of better. So I'd probably do any of the IO TKIs.
Yeah, but then cabozantinib is a pretty hard drug, and then I feel like if someone progresses on cabo, you do not have much left in order to kind of in later lines. So depending on this patient is relatively young, 61, right? So you would think it as like a marathon rather than like a sprint. So I prefer to stay away from cabo initially unless they come with extensive bone mets and because cabo tends to do well with patient with bone mets. So I kind of preserve. So my philosophy is always is kind of go like if XC can do it, I would go with XC first, and with the IO, and just like save it for the later line like Lenpam and Cabo-nivo.
Okay, thank you. So my question would be: are you all satisfied with the amount of data which has come for the combination of TKI with immuno-oncology drug, especially for the favorable risk? Because even in the keynote 426 also, we have seen that for the favorable risk, there was no improvement in the overall survival. The PFS, of course, the hazard ratio was 0.76, but I think the p-value was nominal. The overall response rate, of course, improved by around 18%. And if you see the Checkmate trial very clearly, so there is no improvement in the overall survival when the follow-up was at 17.5 months or 30 months or 42 months. There was no improvement in the survival. And PFS, clearly it was superior for sunitinib as compared with Nivo-EP. So definitely Nivo-EP is not an option for this particular patient. Even if you see the other trials, the CLEAR trial, of course, definitely this is the PFS data. The PFS data shows that for the favorable risk, it is very much to the left of Unity, there is an improvement. But if you see the Checkmate 9 ER, if you see the favorable, it's to the left of Unity, but definitely touching, the confidence interval is touching Unity. And that is for PFS. In overall survival, if you see the confidence interval is crossing the Unity even to the right side. And so with these evidence, so probably the only study which shows a clear-cut improvement in the PFS for this favorable subgroup is CLEAR trial, which was axitinib plus pembrolizumab. So none of the other trials, even the IO the VEGF immuno-oncology combination clearly shows a benefit for the favorable risk subgroup. So my question would be, can we convincingly tell that for all the favorable risk patients, combination is required rather than a VEGF TKI alone?
No, because as I said, it's again, you try to want to make it as personalized as possible. Like I kind of go look at the pathology, look at the site of metastasis, like how the patient is presenting. Is it like, did they have a metastatectomy like 10 years ago? Do they have a pancreatic lesion? So if those criteria are present, I would just go with single agent, because I can hold the disease for like 3-4 years, right? Like in many of those, like even more than that with single TKI. And so I would do that. And the IO, because again, all the toxicity is less, as IO is also not a walk in the park. Initial days, we have patients like who died with myocarditis, et cetera, et cetera. So I'm kind of very judicious, although I'm an immunologist, like as a scientist, but I kind of know the side effects. So, and looking at the data as well, except Pembro-Axi, that trial, which showed some benefit in the like the favorable risk. It also depends on the patient selection, right? And different groups and what was available and stuff like that. So if I don't have to bring it, I don't bring it. I just go with the single TKI if it is. But then if there are other characteristics, clinical characteristics that I feel that, having a immunotherapy upfront might be better, then I kind of go with it. I do a combination. But yes, I agree with you. I would go with a single agent TKI if I can. I have a very conservative approach because, I always look at it like if I'm like running a marathon or a sprint, right? And I pace according to patient's disease pace. And if I have to throw the kitchen sink, I'll throw the kitchen sink. But if not, I'll just go very conservatively with this patient.
Okay, so Dr. Amit, would you agree with her? You would be selecting patients individualized and then treat for selected group of patients whose pace of progression is less, or probably the bulk of the disease is less. You would go with single agent VEGF TKI, and maybe the group of patients where the rapidity of progression is fast and probably the burden of disease is high, you would go for a combination?
Agreed, fully agreed. So we always say individualize your treatment. You see those small few lung nodules really don't need to go in aggressively. You're seeing multiple high burden disease. Those they're sitting in favorable risk with multiple bone, multiple lung, and still the burden looks high. I think that's where a place I would definitely add IO TKI. But otherwise, TKI alone is a good regimen for favorable risk patients, no doubt about it.
Okay, I think so that is quite clear. So we'll go to the next case. 70-year-old hypertensive male with left clear cell renal cell carcinoma post left radical nephrectomy. 9 months later, he came with breathlessness and cough, and imaging showed bilateral lung metastasis and liver mets. His Karnofsky performance status was 70. Labs, low hemoglobin, normal neutrophil count, normal platelets, but high calcium. So this qualifies for a metastatic clear cell renal cell carcinoma of IMDC poor risk. So what would be the preferred treatment for this particular patient? So I'll launch the poll. So what would be the option for a patient with IMDC on poor risk? Axitinib pembrolizumab, ipilimumab nivolumab, lenvatinib pembrolizumab, cabozantinib plus nivolumab, or cabozantinib alone. I think all this have been discussed in detail. And as I repeatedly telling, so all are options. So there is nothing as a wrong answer. So we are sorry for that, the technical issues which have cropped in. Okay, so I think 45% are for ipilimumab and nivolumab, that is an Iuio combination, and that is followed by 18% opting for the combination of cabozantinib plus nivolumab. So I think Dr. Sangeeta and Dr. Amit, your comments, please.
Yeah, I agree with it, because in this question, you can do anything you want, right? Depending on your patient characteristics and everything is approved. You can do it all the whatever kind you want to do at this point of time. But I feel like I would go with ipi-nivo as my first choice, if that is what kind of, based on the data and stuff like that. But yeah, but you cannot really go wrong with any of those options. You can definitely, it's your preference. It's like your patient's like prototype, what prototype, the patient is, and that's it. But ipi-nivo would be my first choice.
So I think the data is quite clear, whether it be the combination of the VEGF TKI or the immuno-oncology agent, or the combination of IO plus IO, or the newer combinations like Nivo, Cabo, or for all these studies, I think the data is very clear cut. When it is the poorest patients, these are all options. So here the NCCN guidelines also tell that for the poor or the intermediate risk patients, all these are options. And so then naturally the question comes, how you choose from these combinations in your practice. I think it has been alluded to previously by both Dr. Amit as well as Dr. Sangeeta. Maybe we can have a reiteration now. So in your practice, how do you choose and how do you decide whether you go for an IO combination or a VEGF TKI IO combination in poorest metastatic clear cell renal cell carcinoma?
So if I feel that, like, the patient, I prefer, if it's a poor risk frontline, I prefer IO combination, unless I see, because for example, I just saw a patient in his initial CT scan, I could see in his ileum there is some inflammation already, right? So there is a chance of colitis if I throw ipi on him. So I kind of chose like TKI, like pembrolizumab on him. But if that was not the case, my always to go is ipi-nivo as frontline poor risk patient. But having said that, if I need a really quick response, have a very high burden of, like, say, liver mets, anything, then I could consider Cabo-nivo. But my approach is always like, as I said before, ipi-nivo, maintenance nivo, let it go. Then if need, then add Cabo on that regimen. Then you continue with Cabo-nivo, because then you can actually like stack it for a longer period of time, and you can have a longer, like you can cover your base for a longer period with this two regimen.
So what basically you're trying to tell is that if the patient is really symptomatic and has a high burden of disease and you want rapid control of the symptoms, you would go for a combination of VEGF TKI plus IO, specifically Cabo plus Nivo, because it showed a high response rate.
But if that is not the case, otherwise I prefer to go like ipi-nivo and then give them a maintenance nivo.
Dr. Amit, what would you do in this scenario, and how do you choose the combination for a poor risk metastatic clear cell carcinoma upfront?
these days, a symptomatic person, high risk, for us, it is IO-TKI is our go-to regime. And so there's been limitations in India. So we've never had cabozantinib, and we still don't have cabozantinib. So for us, cabozantinib is more like a theoretical regime. And secondly, EP came in only a year ago, and we have the other drugs since the last 4 years. So for us, a go-to regime has been IO-TKI for most patients, especially these high burden disease, symptomatic disease, where we want faster responses. And we have become very comfortable with lenvatinib as a first-line IO combination. So we believe the response rates are really good. And that's what we have seen in our clinical practice. So yes, I agree, Axi is a good drug, but I've kind of shifted to lenvatinib to most of my patients who can tolerate it. Now, so I answer IO lenvatinib is my combination, but again, it's not that we'd be thinking of only that option as for our patients. There's definitely axitinib IO-based combinations are good. And IO is something that in India we'll learn soon because we got the drug recently. So it's only recently we've started using first line. So we'll be learning it, how to use it better.
Yeah, I think like IO, I mean, especially with IP, because like my personal experience with IP and as I work with Jim in the lab as well, like EP is very dose dependent and it works. Like if it like really kind of jacks up your immune system, it gives a very, very durable response, even in the preclinical model system. So, but only thing like, I mean, I feel even in US, like MD Anderson is one place where we kind of really heavily use IP. But if you talk to other physicians from other centers like Northeast or somewhere, like then they kind of because it's also institution dependent. Like Hopkins, they develop in here, they develop the anti-PD-1, they prefer both. But I feel that if EP-Nivo, we can combine it, definitely that is like lenvatinib, I don't know, it could be also like, I mean, also we have to take all the data with grain of salt, like none of the Indian population or South Asian populations were not included, right? It was mostly like European or American population. So what are the difference in metabolism? What is the different, like that can also play a huge role because I can say one thing from, I mean, these are anecdotal experiences, but when I give, I mean, XC is like very easy to tolerate when I give it to like white people, right? Like my American, like white people, when I give axitinib, you don't see any symptoms. They are like kind of, as if they are not taking anything. So, but then the same drug, the same dose, if I give it to my African American population, they show a lot of side effects, So, so I don't know, these are still anecdotal. We don't have any prospective data or retrospective data looking at it. But sometimes I feel, is it like, they have a different like, cytochrome system and they are metabolized differently because there has to be a rationale, right? Because even when I give cabo or axitinib in the older white people, I don't see as many side effects as I see even with younger African American population. So those are the things I feel even for Indian population, right? How if they were not included in many of those trials. So I completely agree with Amit that maybe like, lenvatinib might be better tolerated in Indian population, which I'm not seeing with this like, white population. So those are the studies definitely would be important to see like how, different group of people metabolize these drugs differently.
Yeah. So Dr. Amit, what you are telling is that you have moved from pembro-axitinib to pembro-lenvatinib combination now.
I think I would say because of availability of lenvatinib for a long time being used so often, we believe it's a little bit, I kind of think it's more potent than axitinib. So it works more efficacy wise, but it also has more toxicity in certain situations. But we do use more lenvatinib now as first line rather than what we use axitinib.
Okay, thank you. So then we'll go to the fourth case. A 60-year-old man with hypertension, diabetes, presented with cough. CT scan of the chest revealed bilateral pulmonary nodules. CT scan of the abdomen and pelvis revealed a left kidney mass at lower pole with bulky retroperitoneal nodes, and fine needle aspirate of the left lower lobe of the lung was positive for malignant cells, and a cell block with IHC revealed that it is TTF1 negative and positive for PAX8 and CAM5, so favoring the clinical diagnosis of a renal cell tumor origin. So the question is, how would you treat this patient? So would you do a cytoreductive nephrectomy prior to your VEGF TKI or a combination of VEGF TKI plus IO? or a combination of IO plus IO, or you would directly start with a systemic treatment?
So, okay, sorry, very good. Right?
What was the burden of metastatic disease?
So we'll go back.
I missed that.
So lung. So patient presented with bilateral pulmonary nodules. So not heavy burden here we can see, and a few small nodules. I think the opinion is equally divided.
Linu sir, we are running out of time.
Yeah, so I think this will be the last question, and then we will have the discussion, and then we'll stop this. So the results show that 44% would go with cytoreductive nephrectomy followed by systemic treatment, and 56% are for systemic treatment alone. Dr. Amit and Dr. Sangeeta.
Yeah, so we do, if the burden of disease is very less systemically, then we do the cytoreductive nephrectomy first and then do the systemic therapy. But yes, nowadays more and more patients end up with systemic therapy first, and then somewhere down the line they get the cytoreductive nephrectomy. But we still do a lot of cytoreductive nephrectomies. It's just that we are phasing it in a different manner.
Yeah, Dr.
Yeah,
Sangeeta,
my urology team would not touch the patient unless I give them some systemic therapy, you know. So that's why, like, because there are concerns of micrometastasis and stuff like that, right? Like circulating tumor cells. So they kind of, our approach has been do systemic therapy. I mean, for this guy, I would just do maybe like pembrolizumab, right? Or something, and maybe IOTKI, try to get a good response. Then maybe get an nephrectomy, even not on a cytoreductive, right? But let's see what we can get. And then possibly either, depending on the scan was not very clear, I did see one big lesion, right? But depending on how many small they have, we can consider like metastatically or SBRT, whatever we can do, and then kind of try to have a good treatment-free interval for this patient. But yeah, I would go with the systemic before.
Yeah, so we all know that the Carbine trial, which looked at the role of nephrectomy prior to systemic therapy, which was here in this particular trial, sunitinib did not show any benefit. In fact, the sunitinib arm had a better overall survival. But the question is that whether it holds good in the immuno-oncology era as well, or the immunotherapy era as well. So let's have a look at some of the subgroup analysis of few trials. The Checkmate 9 ER study, if you look, those patients who underwent nephrectomy and then who received a combination of Nivo plus Cabo, they did better or had a better hazard ratio for death as compared to those who did not undergo prior nephrectomy. Even if you look at the Javelin study, which combined avelumab plus axitinib, here also if you see the subgroup analysis, the progression-free survival was better, 15.2 for patients who underwent cytoreductive nephrectomy prior to systemic therapy, as against 9.9 months for patients who did not undergo primary cytoreductive nephrectomy. So again, this is an open question. We can't come to definite conclusions. especially when it comes to the immuno-oncology or the immunotherapy areas, or a combination of the VEGF TKI plus the immuno-oncology agents. So any comments, final comments by Dr. Sangeeta and Dr. Amit on this, looking at this subgroup analysis, or can we draw any conclusions, or it's too early to draw conclusions, or we have to wait for a study specifically looking at the role of cytoreductive nephrectomy before an immuno-oncology agent?
I mean, I think my approach would be, as again, we don't have any robust data to kind of make any claim at this point of time, but still I would say that just kind of thinking from the biological perspective, like giving systemic therapy where you can actually kill micrometastasis, right? And if you go for cytoreductive or nephrectomy or nephrectomy, that might also lower the burden of circulatory tumor DNA, because there has been a genetic trial for urothelial carcinoma that showed that, you know, patients who had like high circulating tumor DNA does better if you put like atezo as an adjuvant setting. So if we want to extrapolate the data, but we don't know, I mean, it's apples and oranges, we have to have something in the kidney arena, but if those kind of things like systemic therapy, cytoreductive nephrectomy, then kind of maybe hopefully in near future, we will have circulatory tumor DNA assays and everything available. And that would help us make a decision like, how do you just observe them, or do you keep them on maintenance immunotherapy?
Okay, so thank you to all the panelists. Since we are short of time, we'll skip the last question as well as the discussion for the last question. And now over to Dr. Santosh.
So thank you, Dr. Sangeeta, Dr. Amit, for your very good insights in management of first line and second line metastatic RCC. I'd also want to thank Dr. Vishwanath for lucidly putting forward the role of Nivolumab, and Dr. Linu sir for the moderating the question answer session. I'll also want to thank BMS, Panacea Biotech, and Adley Oncology for the educational grant, and the attendees who have logged in from various parts of the country. Thank you and good evening.
Thank you so much.
Bye. Thank you.
Thank you. Bye.